Hello everybody, my name is Jenny Pearson. I'm a Professional Development Officer for the Primary Health Network. Welcome to 2021 and another exciting year of education. Just before we begin the meeting, I'd like to acknowledge the traditional custodians on the lands that we all meet on tonight and pay respect to elders both past, present and emerging. Tonight is being recorded and a copy will be put on our website. Under Education, you will see a tab called Education Library, where you will be able to access the recording and the slides. Our presenter tonight is John Bailey. He's the Executive Manager of the Primary Care Improvement Team. And we also have Karen Douglas present as a panellist. Karen is a GP from Terrigal and Avoca and is the chair of our Central Coast Clinical Council. I think that's all from me, so I'll hand over to you, John. Just before I do go, don't forget that you can type in questions and we will be answering them during the presentation. Thank you.
Thanks, Jenny, and welcome everyone. I too would like to acknowledge the traditional owners of the lands on which we meet and pay my respect to elders past and present. Thank you for taking the time to attend this vaccine, COVID-19 vaccine EOI update. I'm just going to preface tonight by saying that we still have many unanswered questions. So if you can type those into the question section, even if we can't answer them tonight, we'll make sure that we do get those answered and put them out to as many people, or get them out to the audience as soon as we can. Jenny, would you mind going to the next slide? Thanks. Just to reiterate that the slides from this presentation will be circulated after the webinar, so there's no need to take extensive notes unless you want to capture what I'm saying, but as we've said, this is being recorded as well. Just a couple of key contacts for the EOI. There's my contact details there, and also my colleague Kimberly Booth. Also need to note that any potential applicant can seek clarification on this EOI by sending an email to the email address primarycarecovidvaccine@health.gov.au. Questions and responses to that email will be shared with all applicants if relevant and appropriate, and that will be across the country. Thanks, Jenny. Just wanted to do a bit of a quick update on the vaccine status as we know it. Now, I have to note that this is changing daily. So we have an approved vaccine currently for Australia, and that is the Pfizer vaccine. And I've, just to help you along, put the full title of the vaccine there. This is now provisionally approved with a rollout to the priority groups in phase 1A of the government's rollout plan, commencing mid to late February. But I just wanted to also inject a note of caution here that this is a fully imported vaccine and that there are competitive international markets at play. So that date is an indicative date at this stage. The Oxford AstraZeneca vaccine is still subject to TGA approval, but we're anticipating that that will occur this month. Being January and possibly into the first week of February, with a rollout to priority groups in phases 1B through to 2B, and I'll walk through what those groups look like in a minute. Just for noting that this vaccine is manufactured onshore here in Australia, so it is not so influenced by the international markets at play. Also note that Australia has signed up for the Moderna, Novavax and Covax vaccines and a couple of others, and they're expected later in the year subject to the clinical trials and TGA approvals. Thanks, Jenny. Just want to comment on AMSs and GP respiratory centres. Apologies for the spelling mistake there. These are subject to a different process and are an opt-out process and being run directly via the Department of Health. In the case of AMSs, that will be through NACCHO. The general practice process is an EOI process that was launched on the 22nd of this month and is open until the 1st of February, with incremental sites being added based on the availability of vaccine and the ability of practices to do volume and pace. Thanks, Jenny. Just want to talk about the phase 1A population and target group. So as I've said, the Pfizer vaccine is transported and stored at -70. It has in the product advice, which was released at the weekend, a 15-minute observation period and was approved by the TGA on the 25th. Currently, the packaging is 1 vial of 0.45 mils, and that contains 6 doses after diluted with 0.3 of a mil of dilution fluid. Also, you would have heard us talk in the media about vaccine hubs. The vaccine hubs, Jenny, thanks. Vaccine hubs are the places where the Pfizer vaccine will be stored and distributed from. We know currently for our footprint there is one nominated, and that's the John Hunter Hospital, and there are several already approved for Sydney and more likely to come on board in coming days and over the next few weeks. Delivery to the 1A group of patients and staff, etc., will be via various lead agencies, including local health districts, private contracted providers for residential aged care facilities, and those private contractors are Aspen Medical, Healthcare Australia, International SOS, and Sonic Clinical Services. The group for cohort of people for this particular round are frontline at-risk healthcare workers, including staff in GP respiratory clinics, COVID testing facilities, ambulance staff, paramedics, ICU and emergency department staff, clinical and ancillary support staff in public hospitals. We are currently seeking advice on whether or not GPs undertaking COVID screening in their own practices will be included in this group, and I hope to be able to provide that information later in the week. Also in this group are residential aged care staff and staff working in disability care settings. This includes GPs who visit those facilities and includes allied health staff who visit those facilities. All residents in those facilities will be offered the option of having the Pfizer vaccine, as well as those in disability care settings. Quarantine and border workers are also in the Pfizer 1A phase. Next slide, thanks Jenny. For the 1B phase is to be the AstraZeneca vaccine subject to TGA approval. The reason for that is that transport and storage is between 2 and 8 degrees Celsius. We believe that there will also be a 15-minute observation time, but all of this is subject to TGA approval. It's anticipated that this rollout will commence from mid to end of March and onwards. Primary care networks will have a role in the coordination and support, and I'll talk about that a little later. The target cohort for this particular phase are adults over 70, all other healthcare workers, including general practice and primary care workers, and begin to vaccinate Aboriginal and Torres Strait Islander people, younger adults with underlying medical conditions, including those with a disability who are not in a residential facility, and critical and high-risk workers, including defence, police, fire, emergency, and meat processors. Just going to talk for a second about meat processing. As part of what we saw in 2020, we saw that people working in meat processing plants, for some reason, had a higher incidence of COVID-19. As a result of that, the immunisation advisory group to government have prioritised that group of workers. For those working in meat processing facilities in our footprint, they'll be included in that priority group. So if you've got an abattoir in your facility, they'll be in your footprint, they'll be included in that group. Next slide, thanks Jenny. For phases 2A and 2B, PHNs will again play a coordination and support role. For phase 2, AstraZeneca, transport and storage 2 to 8 degrees, expected to be a 15-minute observation time, and again, all subject to TGA approval. This group are for adults over the age of 50, Aboriginal and Torres Strait Islanders between 18 and 54, younger adults with medical conditions, including those with a disability who live at home, and other critical and high-risk workers, and they've not been defined as yet. Phase 2B is again the AstraZeneca vaccine, 2 to 8 degrees, 15-minute observation period. And this is for the remainder of the population, but also an opportunity for people to be caught up on if they've missed out in the previous phases. Just need to note that it is not anticipated that these phases will be done sequentially. The expectation is that some of these phases will overlap, and I'll explain the reason for that shortly. Thanks, Jenny. You will have heard about phase 3, and phase 3 are for people under the age of 18. It has not yet been determined when or how that will occur, or the vaccine to be provided. And the reason for that is that there is limited clinical evidence for that particular age group, and further clinical trials need to be conducted and the evidence gathered for that. So that age group will be subject to further TGA approval. Thanks, Jenny. All right, just want to talk a little bit about some of the limiting factors and some other issues. The limiting factor for all these phases is the supply of vaccine. For the AstraZeneca, there is probably a better chance of a more stable and faster supply because it's produced onshore, and the production mechanism is slightly less complex, as is the storage and distribution. It can be distributed and stored in the same way as our other vaccines have been. But again, the supply of the vaccine will be the limiting factor. The aim is to deliver as many vaccines at pace to the target audience, or to the target cohort. The current advice is that 2 doses are required, and that must be a month apart with the same product. So if you have the first dose of Pfizer, then you need to have the second dose of Pfizer. If you have AstraZeneca as your first dose, you need to have AstraZeneca as your second one. Just a couple of other things. The government have determined that this will be free for patients, and MBS items and PIP arrangements have been communicated in the EOI. This activity is exempt from the 80-20 rule, the same as COVID screening was, and for GP and other medical practitioners. There are some co-billing questions which are being clarified, and as soon as we understand what those are, we'll get that information. I'm expecting those to be answered in the next 24 hours. There is no separate item number for authorised nurse immunisers. Vaccination is completely voluntary. Thanks, Jenny. The selection criteria, the process and outcomes. The Commonwealth will receive and review all the EIs in accordance with the following criteria. I'm not going to read those for you, but they're contained in the EOI document. Thanks, Jenny. Primary health networks will assist the Commonwealth in coordination, planning and delivery of this vaccine rollout, including liaison between yourselves and the department. Happy to take up any questions for you on your behalf with the department, and also encourage you to use that email address that was in the second slide that I provided. The Commonwealth will be providing prioritising applications based on the criteria on the previous slide deck. But ultimately, the Commonwealth will decide which sites are chosen, not the PHN. Thanks, Jenny. Just wanted to give you a little bit of as close to real-time data as I can. As you know, the application process is via an online portal. Behind that are some fairly sophisticated business analytics. What you can see on the screen at the moment is at 10 past 5 this evening, we had 70 submissions in our footprint. There were 1,500 expressions of interest in the portal nationally. Our first submission occurred at 9:46 on the 23rd of January, so fairly quick off the mark. Please don't worry too much about the colouring in the map. That's just so that it's visible at an LGA level. Thanks, Jenny. Just want to talk about what's known and what's not known, and then we'll move through to a couple of other items. So what's known is currently there's one hub nominated for the 1A phase, and that's in the Hunter at the John Hunter. I've been asked a couple of questions and I thought I might answer these preemptively. Can a practice withdraw its EOI? The answer is yes. All you need to do is notify the PHN via the 2 email addresses that were in the slide deck at the beginning. We'll arrange to have your EOI withdrawn. Can you change or amend an EOI? The answer to that is yes, by resubmitting your EOI with the amended information, and let Kimberly or I know, and we will arrange for the original application to be archived and your most recent application to be taken forward. I've been asked the question of what do we do if a practice wants to pool its resources with neighbouring practices? And the answer to that is that all practices who want to collaborate and work together to maximise their workforce or the space or whatever should submit an EOI. And the fact that they intend to work collaboratively should be in the free text sections of questions 37 and 42 in the online portal questionnaire. What I don't have much information on at the moment is the details of the national booking system, but this will be available by the end of the week. I also don't have a lot of information on the co-billing, and we've sought clarification, and we've been advised that that will also be in the EOI towards the end of the week. Thanks, Jenny. Just wanted to highlight on behalf of a couple of our GPs some local resources and links, and thanks to Karen Douglas and her colleague Ellie Warren for this information. So the first one is the link to the New South Wales Health and RACGP COVID update webinar, and you can see the YouTube link there. I'm not sure about grabbing a tipple of your choice, but that's Karen's recommendation. So there's also a vaccine rollout strategy document which is available at the website of the department, and again I'd suggest you have a look at that. For GPs on the Central Coast, there is a COVID community of practice which is being run through Basecamp, and the details for that community of practice are on that slide deck, and we'd encourage you to participate and connect with your colleagues. And finally, the contact details for Dr. Ellie Warren and Dr. Karen Douglas, if you have difficulty registering or if you've got any questions, are on the slide deck. Thanks, Jenny. We might just go back to the original slide, and I'll start answering the questions from the the online questions. So the question is the vaccine compulsory for residential aged care facilities? If they refuse the vaccine, what paperwork is required? Okay, the process for the COVID vaccine is no different to any other vaccine. The consent process is exactly the same as if you were intending to give the resident the influenza vaccine. They can refuse, and what we're asking is that residential aged care facilities keep a record of that, but also in the capacity tracker that the PHN has rolled out, there will be a field to register the number of people, both staff and residents, who've declined the vaccine, just so that we can help with communication and help answer any questions. Next question is, will students in clinical placements, e.g. nursing, medical, be included in 1B? That's a really good question, and it's one that I'll direct to our colleagues at the local health district. My instinct tells me that it will be based on the place, the area they're working within the facility, and prioritisation will be provided clarification will be provided by the local health districts and facilities. How's Medicare going to view the visits with respect to the 80-20 rule? The 80-20 rule will not apply to COVID vaccine administration, just the same as it didn't apply for COVID screening in 2020. Should visiting allied health professionals visiting RACFs be included in the RACFs numbers, just as GPs? The answer is yes. If you're an itinerant worker in a residential aged care facility, we would encourage you to let the facility know to count you in the numbers. The whole idea here is obviously to protect that community, or to protect the people living in those facilities. Can you advise if general practice admin reception staff are included in the initial vaccines for GP healthcare workers? The answer is yes, absolutely. Again, about protecting people who are working in those areas. Why are GPs not considered frontline workers? Look, the issue here is one of prioritisation. As Karen has said, Phase 1A will include GPs who do COVID swabbing in GP respiratory, and all GPs who have a resident in a residential aged care facility. And we're seeking clarification from the department on practices who do high volume respiratory screening at the moment. And once we get clarity, I will provide that again through our normal comms processes. What if a patient still refuses? Are they putting other residents at risk? Look, those are good questions, and they're ones that we will pass through to the department. It is a difficult situation. What may occur, and what we suspect might occur, is that some people will refuse the Pfizer vaccine, but may be happy to have the AstraZeneca, in which case we'd encourage residential aged care facilities to record that, and we can accommodate that in later stages of the rollout. Will there be a Commonwealth or standard consent form? Hopefully this is being sorted out through the national booking system, as Karen has said. And again, once we see that system and have a bit of visibility over it, we'll be able to clarify that. We're also aware that the Commonwealth have been talking to as many of the indemnity providers as they've been able to clarify their position on this based on a consent process that may not reflect normal general practice. Okay, next question. Will everybody who submits an EOI complying with all other requirements be allocated vaccines? If not, how will decisions be made about who's granted vaccines? As I said in the slide deck, and I keep saying to people, the whole intent of this rollout is to vaccinate as many people as we possibly can, as quickly as we can, safely, but within the constraints of the supply chain for the vaccines. We will initially be prioritising practices based on the criteria that I talked about earlier, one of which is the ability to vaccinate quickly and in volume. So we'll be looking at that data and providing advice to the Commonwealth on that. Where we have competing practice, or sorry, not competing, where we have practices who have similar profiles, that is, they're able to vaccinate similar numbers, we will put them through together to the Commonwealth as an equal priority. So we're not going to pick winners, we're going to try and get as many in as we can. Can I clarify who the audience is? It's for everyone. Look, we just want to get information out there. We're aware that social media is rampant. Karen and I and the chairs of the Clinical Council met on Monday night. And one of the things that we said is that we need to get clear and concise information out as quickly as we can. I have to say that this is being developed by the Commonwealth on the fly, and as they get advice from vaccine producers and from TGA, etc. But we are moving with this as quickly as we can, and we will get information out as quickly as we can to everyone. Someone's rung the department and told us they don't know. Look, can I just say to you that the department are moving quickly on this rollout, and parts of the department may not quite be in the loop, same as we're not, but as soon as information is available and it's publicly shareable, then we're getting it out as quickly as we can. The intent is to repeat these webinars as frequently as is appropriate, and I'm going to ask my colleagues at the LHD if they would do a webinar in the next couple of weeks about the various clinical aspects of the vaccines that are in approval or being considered. Can it provide a charger consult on top of the immunisation if they're required to face-to-face on the phone for any? Look, Karen says correctly that it appears that that's the case, but we're seeking clarification. And I am assured that that will be answered in the FAQ, frequently asked questions, in the next 24 hours. Will the PHN consult with support practice nurses on the logistics of vaccine clinics? They've got a lot on your plate, and the model's been designed by administrators. The model's been designed by the department on the advice from a whole range of peak bodies, including APNA and others. We've been inputting through as many clinical forums as we can, and absolutely we'll try to support general practice nurses and residential aged care facilities and others as best we can. Now, are GPs being vaccinated in 1A or 1B? Mainly in 1B, but those working in critical care facilities. So let me use an example. Someone working out in a rural setting or in a just respiratory clinic, or where they're swabbing in numbers in their general practice, we will be considering those for part of 1A. But again, that's a choice for, that's a decision for the government. Audio not working, hopefully that has been resolved. The EOI form asks, who is the notice representative at the general practice? Okay. The notice representative is the person or the individual to whom you would like communication sent based on your prioritisation. In other words, who would you like the responses from the PHN or the department to go to? Is it the practice principal, the practice manager, or some other person? So you just need to nominate someone to receive correspondence from both ourselves and from the department. Just sort of working down through these as best I can. A parcel delivery person asked me when they'll be eligible as they handle parcels from across many countries. Look, again, as Karen said, really good question. Probably getting down into the detail, but it would depend on where they fit otherwise in the cohorts. They could be in 2B, 2A or 2B. And the department may in fact prioritise other groups in 1B, but we haven't seen anything of that level of detail, although I'm sure I'll get questions like that quite often over the next few weeks. Because we have to accept patients that we've never seen and before, at our practice before, not a problem. But what about the PMH, and it's expected to take less than 6 minutes? Look, it's a really good question, and as Karen says, we're seeking advice on that. We don't know to what degree the national booking system will interface with your desktop software or your software, but we're certainly asking for that to be clarified. Will the vaccine be a one-time vaccine like the flu vax, or be needed annually? Look, the jury's out on this, and I think if we can carry that question forward into a forum where we have our clinical leads from the LHD, I think it's a question for Dr. David Durheim or for Dr. Kat Taylor from the LHDs, but I'll get them to clarify that. Just while we're talking about flu vax, we do know, and ATAGI, the Immunisation Advisory Group, provided advice late last week, early this week, that there needs to be a 14-day separation between administration of a dose of the COVID vaccine and administration of the influenza vaccine. So, you know, there's no particular order in which they can be given, need to be given, but it conceivably could be COVID vaccine, wait for 14 days, give the flu vax, wait for 14 days, give the second dose of the COVID vax, or any combination thereof that you can think of. It's also likely that the government will issue advice this year on the timing of flu vax based on the experience last year, where there was very little influenza circulating in the community. But again, we'll wait to get advice from TGA and government on that. Is telehealth, sorry, RGP admin, we've already answered that. Is telehealth being axed in March or extended? Good question. I haven't heard anything, but I'll ask that question via email tonight. Probably should have done that. Why does everything about the standards for delivery completely undermine the efforts towards, take that on board, but it's not my decision about the rollout. Are there any planned local vaccination hubs on the Central Coast at present? Look, Gordon, we don't know. All we know is that there are, I believe there are 3, Karen, in Sydney that we've been made aware of, and there's the one at the John Hunter. They've indicated, they being the Commonwealth, have indicated that there'll be between 30 and 50 hubs nationally. So we'll need to just wait.
Hi, John, and welcome everyone. Yes, I believe that there are 3 hubs that have been named in Sydney so far, mainly to look at the areas of high clinical importance, really, where COVID has been present, and they include RPA, Liverpool and Westmead. So those 3 hubs have been named, and then John, you've told us about the Hunter. So they're the only ones we know of at the moment. That's right. And look, one of the Sydney hubs will be responsible for delivering vaccine to quarantine and border staff who are another high-risk group, and Australian-based air crew who are another group as well.
Will clinical staff providing COVID vaccines be phase 1A? No, probably phase 1B. But again, Simon, we will be sub-prioritising those phases, if you like, and certainly recommending that clinical staff be in the first order of 1B. In the case of a practice that's GPRC or GP respiratory clinic, they will be 1A. Slightly confused as to why GPs are not frontline workers. Look, again, hopefully we'll be able to provide more detail on that, but it's about the risk profile and the prioritisation of what is going to be a very limited resource, particularly initially. Again, I'll come back to the fact that we're importing the Pfizer vaccine, whereas we will be able to manufacture and probably scale up in a greater way the AstraZeneca. Fiona, are PHNs involved in the selection? Look, we'll be prioritising them, but we won't ultimately do the selection. What we've been asked to do is to check some of the information. We've already got a couple of typographical errors, if you like, in some of the EOIs. So we'll be working with practices and the department to resolve those. What's the time frame for phase 1B? TGA approval is expected soon, and as Karen said, probably not until mid-March, late March, or even early April. It's, again, all dependent. Is there likely to be another distribution? I think we've talked about that. There's talk about using the in-reach workforce that I talked about for residential aged care facilities. So that's the Aspen, Healthcare Australia, International SOS, etc., to do some mobile clinics, and they will be used in other parts of the country for quite remote populations. So there is some work being done around that, but it's early days at this point. If the practice is, for the EOI, if the practice is accepted, do they see all patients, not just theirs? Yes, they will be asked to see all patients, not just theirs. Will GP practices that are not 1B centres find themselves in the position they have to travel to another practice, I assume that, in order to have the vaccine? Look, it depends on the availability of the vaccine, and they may have to go to another centre. It's too early to be able to answer that because we don't know what the supply looks like. Will the 15-minute observation period be able to be undertaken in people's car parks under supervision? Look, that's a really good question, and I posed that to the department. The department have no issue with a model that has if you like, observation area where you would appropriately socially distance people, and they then are monitored by an appropriately trained staff member, a registered nurse, after having been given the vaccine somewhere else in the facility or on another site. Again, they just need to be well monitored. Will Archos vaccinate only their own population in 1B or expected to vaccinate Aboriginal and non-Aboriginal clients who access mainstream? People have a choice of where they want to go. It's as simple as that. You know, if a patient is a regular patient of an AMS and that AMS is a part of the 1B phase, then I would expect they would choose that as part of their system and process. Pregnant women, look, what I will do after this webinar through Jenny is we'll circulate to you the product information advice that has been provided on the Pfizer vaccine. So if you're one of these people that likes to read those things, you can read it. And Karen has answered the question that not to pregnant women nor breastfeeding women at this stage, as there's limited clinical data, and that's exactly what the sheet says.
John, the College of ONG today have put out their recommendations. So if we can certainly give you a link to that as well. It's worth reading, and that's what they've really said. Watch this space, because in Israel they are actually vaccinating pregnant women. So we'll actually get a lot of data from other countries quite soon. So by the time we're into 1B, Australia will probably know a lot more, I think.
Yeah, I completely agree. And if there is a benefit from being a relatively COVID-free country and being slightly delayed in terms of our rollout, I think the increasing evidence from overseas is one benefit we can take from that. So yeah, good point, Karen. I've seen information saying that a nurse can bill on behalf of the GP. We're seeking clarification, but I don't believe, Samantha, that is compliant, but I'll check and get back to you on that. And I think the next question is exactly the same.
John, can I give you a bit of feedback about that?
Yeah, give me your interpretation.
Yeah,
So,
from the college's point of view, and from what I've read today from AMA as well, is that the GP it doesn't necessarily need to be the vaccinators, as we know. They'll be the supervisors, and as long as you have a good system in place, very similar to probably your flu vaccine clinics, where a GP is the medical supervisor on behalf of your practice and is available for assessing patients with known allergies and previous anaphylaxis, reasons why you may not vaccinate them, is aware of the people in the building and that being vaccinated. It probably will be very difficult to say that GP, if they're getting on with their normal business as usual and doing their very busy other practice, that they would actually be okay. But if there is a GP and say 5 nurses vaccinating or a couple of people vaccinating, then yes, it is that the nurse will be able to do that on behalf of the doctor.
Thanks, Karen. Appreciate that. That's good advice. Is there a guideline on how long each vaccination appointment should take? The EOI requests to nominate how many appointments can fit in a clinic, but we don't give an indication of how long we need. I'm guessing 10 minutes per patient at least. Karen, you're a practicing GP. What are you thinking?
Look, I think we all know in general practice that if you know the patients well and you have their medical records, and you can ask the question of known allergies, previous anaphylaxis, you've got all the data in front of you, you probably can vaccinate somebody quite easily in 5 minutes. But if you have to gather all of that information clinically for any new patients or any person who is complicated, it's going to take you longer. So we know in our flu vaccine clinic that we have held, we booked 5-minutely. But we had to have capacity to do so. We had to have the nurse vaccinating. We had to have admin assisting us with the flow of patients. We had to have people watching and observing after the vaccination as well. So it depends on capacity really of the practice. 10-minutely appointments, John, will never get through the population and the community that we have to vaccinate.
Yeah, and look, I've taken calls from a number of GPs and practice staff saying, look, what about operating after hours? What about extending our time? Those are all decisions for the practice and to consider when they're looking at the EOI in terms of the volume that they might get through. Phil Godden's asked, is Gosford Hospital doing 1A? At this stage, there is no information on which facilities will be doing it. All we know is that the hub is located at the John Hunter. Now, the hub is both a centre for administration of the vaccine for 1A, but also a storage facility. One point just in relation to the hub at the John Hunter, Newcastle has a very active port, and we do have large numbers of overseas sailors who enter the country via that port. So that's another reason that John Hunter's been nominated pretty early in the process. Well, I think we've answered the question around the authorising and the GP giving. Again, we'll seek clarification. Renato, an EOI is an expression of interest. So it's an expression of interest. What is the different procedure for phase 1 vaccine delivery? Are eligible healthcare workers invited or self-present to the John Hunter? The booking system for 1A is being worked out. My understanding is that for the for the LHDs, they will be responsible for that process, and they'll communicate that to their staff. I apologise, but I don't have visibility over it. Perhaps in subsequent webinars, we can ask the LHD staff to provide clarity for their, Can a registered nurse administer the vaccine at the residential aged care facility? The answer to that is currently no. That the InReach workforce from Aspen, Healthcare Australia, SOS, and others will take care of that. But again, look, this is evolving, so we just need to wait and see how that evolves. But at this stage, no. From a planning point of view, go on, Karen.
Can I just say, everyone, there's been some fantastic work come out of Victoria. And one of the major points that the Victorian GPs have actually shown from when they had their second surge of COVID was that GPs must remain involved, and that even though our GPs and our nurses won't be actually actively putting the needle in the arm of our nursing home and aged care residents, we must be involved in gathering consent prior to it and being involved in making sure that we identify those who should have the vaccine, and also think about what's going to happen if there's any adverse reactions afterwards, maybe after the first day of vaccination, because we know the contracted service providers will be made to observe the patients, the residents, for the time that they have to. And then also the GPs must be involved in making sure that we identify those people who need their second shot, because not everybody will have their second shot, and some may be so frail and end of life that they may not be vaccinated. So we must stand up and actually be involved right at the beginning. And I would suggest that everybody who has residents as patients in aged care facilities, that you start getting them consented now. Talk to their relatives and talk to those who actually have capacity to make their own decisions, so that you can give them some informed advice.
That's good advice. Yeah, good advice. From a planning point of view, there are 1,000 clinics expected to step up in 1B. Do we know how many are expected or needed in this region? Joe, the number of 1,000 has been circulating in various circles. I asked the department today, they do not have a number. There is no number. The issue is the limiting factor of the availability of vaccine and the supply. All all general practices who put an EOI in will at some stage be able to administer the vaccine. Again, the constraining factor is the supply of the vaccine. So When do you see education being rolled out? Hopefully soon. Thanks, Karen. You're channeling my thoughts there. We've been told that the education is being final checked and tested, and it should be out and available soon. Do you have to use the national booking system? The answer is yes. The degree to which it will interface with general practice software is being worked on now, but the answer to the bottom line on the use of the national booking system is yes. And the reason for that is to allow the targeting of the cohorts in a fair and equitable way across the country. Do we know if the national booking system is the only way people can book, and if so, how will this be? This will be an issue for the older population. Good comment, Melissa. I've raised that with the department. We understand that there will be a mechanism for phone and others as part of the national booking system, but I'm yet to see the details. As soon as I do, I will share it with everyone. GPs who work in GP access in after hours clinics at hospitals 1A or 1B. Not sure, Renee, but I'll get some advice and communicate that back through the management team at Hunter Primary Care. So a rural GP who visits the RECF, how will they access phase 1 rollout if visiting John Hunter is logistically difficult? Susan, we believe that the InReach teams will take the vaccine to sites and then will then administer it on site. They'll obviously need to let GPs and other workers know when they'll be there so they can attend. For some rural sites, it may be that the local health districts are doing it because those sites are either nursing homes operated by the local districts or on behalf of the local health districts, so MPSs, for example. Under the workforce requirement, would a receptionist doing their normal role be considered to fill the role of concierge or team leader? I can't say why not. Yeah, I agree, Karen, good, yeah. Any idea what quantifies volume and pace? That's really what you can do. I mean, there is no bottom level, and I suppose there's a top level, and that based on reality of how many hours a day you can work with the workforce that you've got and the number of days a week. So, but there's no bottom level. Isn't it?
John,
yeah,
can I just, I guess,
yeah, please.
yeah,
getting
I know you must be getting tired. What I think we need to all be very mindful about, and this is something I would totally encourage all practices to think about, is capacity is going to be a really big problem for us. And we know that we're all very busy and that we want to be able to vaccinate our own patients. We know them the best, and GPs need to be involved in that. The government have only got limited supply when it first comes in. That's why they've actually done it this way and asked for EOIs. So hopefully it will be open to GPs to be able to catch up and assist in vaccinations once there's enough supply to go across the country. However, I would encourage you to put an EOI in. I think it's really important to let John and his team know that you're interested to vaccinate your patients at least, and maybe the limitations that you have in your practice, and put those, as John suggested, in free text towards the bottom of the EOI as to what your concerns are and why you may not be able to do the volume and pace that you feel very anxious about, which I feel anxious about already, knowing that we need to get 30 million vaccinations done. That's 2 COVID vaccines. Then we have to put a flu vaccine in there somewhere, and we still have to run our really busy practices. But put an EOI in, because even if it goes to the Commonwealth and you actually get chosen, you're not going to, if it is a reality that you can't meet what they need you to meet, then you don't sign the contract, is what I see. But I'd encourage everybody not to stand back, but I also understand totally for those practices who feel very concerned about putting an EOI in, that other practices around hopefully will assist in being able to do that. The other, I would just put a call out, if anybody is interested in looking at the feasibility and going to government, and I think PHN, John, you will help us do this, is maybe look at some GP hubs, some community settings in which general practices might be able to go to vaccinate, where we can share resources and share access, but still see our own patients, and maybe some from the community in hours and after hours. Just a thought, and it's something that I think our PHN will go to government and advocate for us.
Sure, I raised that today. Again, the department have asked practices who wish to work in that way to note it in the free text, so that we get a sense of what level of interest in that different model there is across our footprint. So please, I implore you to put an EOI in. You can always withdraw it, but if you don't put it in, we don't know the level of interest or some of the issues that you're raising, which are all very legitimate and appropriate. Again, you can put a forward date in to commence. There is a question which asks you when you think you might be able to commence. So, you know, if you want to hedge your bets, you can do that there as well. Just rolling through some of this. Will the vaccine be distributed regularly, e.g. weekly? Good question, Melissa. We don't have a lot of details over the logistics at this point in time. As you have heard, we're waiting on approvals. I suspect that it will be a regular supply. As the production ramps up, that the frequency between supplies will be less stretched out. That's one of the reasons for the use of the national booking system, is so that the bookings can be matched to the supply of vaccine on the ground. Does the PHM reckon the Fiona, I'm not going to go there. Karen's already dealt with that, and it's above my pay grade. How is the immunisation?
John,
yeah, go
John,
for
I'm happy to just give you a couple of seconds on that, Fiona. Good question. I've been crunching numbers today, and I'm scared. I think it's certainly viable if you've got the workforce already there, but we know that we're already very busy yet again. So it is probably viable, and particularly when we think that there's going to be perhaps a number of nurse vaccinators with a medical supervisor, such as 1 or 2 GPs, but it probably is going to be very difficult to actually gather more GPs and more nurses into every practice to do so. So again, if we can put other item numbers onto our consultations, particularly if we don't know the patient, their first time to our practice, and we need to gather some history, then there should be no reason why you can't add an item number to that. The other item number I'm thinking of, John, nobody's actually brought this up, is the nurse-initiated item number for a patient who's already got a care plan or a GP management plan in place in your practice. As we all know, there's 5 available visits for those patients who actually do already have a care plan. So I see no reason at this point that can't be offered as well to the GP.
Yeah, look, that sort of option is one that I'd be interested to get a little bit. I might get from you an email with some detail of that, and I'll ask MBS or the department to clarify and make sure that I don't have to come and visit you in Long Bay.
Thank you.
How is immunisation registered in the AIR? Or do we have to give an immunisation passport? Look, there is significant technical work being done right as we speak to interface AIR and general practice software to be able to automatically provide the information to and from the AIR. I haven't seen it, but I'm told that that's well advanced, and that the various product vendors will be updating software in the next few weeks to take care of some of those elements. Melissa Payne, do you have to use the national booking system? Well, I've already talked about that. would the first aid staff be automatically filled by an RN? So yes for the RN, but for receptionists only if they have a current first aid certificate. So yeah.
Yeah, I think the other thing is, John, that first aid is something that we GPs do all the time.
Yep. I was going to say,
in our practices, first aid is, but in your EOI, of course, you're going to say yes, you can actually give first aid.
Yeah, good point. Aboriginal community controlled do not need to submit an EOI. Absolutely correct. You do not. If you're working in an Aboriginal community controlled organisation, submit an EOI. There will be a separate process through NACHO for that. Oh, sorry, I missed the question about visa holders without Medicare card. The government is providing the vaccine for all Australian residents and all people living in Australia. There will be mechanisms for people who don't have access to Medicare, and they'll be clarified in the next few days. So it's a really good question, and for some of our populations, that's significant.
I would see that these kind of patients, and we see them often, will probably be able to be provided their vaccine at somewhere like a GP respiratory clinic, which is not through Medicare. It's through the it's through the Department of Health funding.
Direct contract, yeah,
contract,
absolutely correct, yeah. I guess the question is, what if they're in a rural area and there's no GPRC around? Then we'll need to work through that. Again, part of this evolving space. Any idea what to do with returned travellers who've had their Pfizer dose overseas and need a second within 12 weeks? My understanding that's been worked through with government and the border and quarantine organisations, and I'll come back to you on that, Ellie.
John, there's just there's not much evidence at the moment about mixing the vaccines, but again, from overseas data, we may well have that information sooner than later, particularly because supply is the biggest issue, and you've just heard that coming across today. So there are a number of countries, I believe, that have decided to mix the vaccines for number 2. So again, Australia's in a good place to probably see what's going to happen with those. But certainly it does appear just from the discussions that I'm seeing so far is that those who've had a Pfizer vaccine and have returned vaccinated will be in 1A, or will be able to get the Pfizer vaccine as their second dose.
Sure. Yep, good point. If 1A is being administered at the John Hunter Hospital, does that mean the eligible people need to travel there, including RSCFs? No, residential aged care facilities and staff, residential aged care residents, disability group home individuals and the staff will be vaccinated in situ. The John Hunter is the hub for distribution of the vaccine, not for all encompassing administration of the 1A. So just to be really clear that residential aged care facilities will be done in situ, that is in the facility. We've already talked about the need to immunise all comers, but again, as Karen said, encourage you to do an EOI, so at least you're in the mix for your own patients. For 1B, is an additional first aid provider required over and above the vaccination team? No, I think we've answered that pretty well, Karen. When should flu vax be introduced this year? Delay or work on 4 weeks post-COVID? Look, the jury's out on that, Mandy. What we haven't heard from government, from TGA or anyone else at the moment, is when the flu vax will be released. What we do know is there needs to be a 14-day delay between the administration of the flu vax and COVID, or administration of the COVID and flu vax, which I think I covered earlier. What's the process for AMSs? To all the stipulations, there will be a separate set of documents for AMSs, Jordan. So you can, we should be able, or we're told that should be out in the next day or so. What happens if to the PIP if the patient gets their second vaccination at another clinic? Unfortunately, Ira, it is not payable.
No, that's true. That will definitely be true. So another real reason for if we're going to be involved in this process that we need to be encouraging our patients to come back to get the extra $10 PIP.
Correct. I've also had a question that I've taken up with the department. Why is there a differential between the first and the second dose in terms of the remuneration? So for MMM1s, I think it's $30 for around $30 for the first dose and $24 for the second, when essentially it's the same piece of work. A good question, and I've taken that up with the department and expect them to clarify that in the next couple of days. Is there guidance on waiting room distancing, et cetera, et cetera? The rules that are in place under public health orders apply at the time. So if it's a 1.5 metre separation or 2 square metre rule or 4 square metre rule, it's whatever applies at the time. And frankly, they're changing all the time. So you just need to work out what's happening. Vials, how many doses per vial? Look, at the moment, Samantha, we're told that there are 10 doses per vial. I'm just a bit cautious on that because we were told there were 10 doses per vial of the Pfizer, but in the product information sheet, it actually says 6. So we've been working on the premise that it is 10. And how long will, once it's made up again, that'll come in the product information sheet, but I would expect it similar to the Pfizer vaccine.
John, can I just make a comment which I don't think we've covered yet, and that's about certainly about the multi-dose vials, in that you will need to have an appropriately trained person to actually draw up these vials, and you'll need to be able to do timely vaccination from these vials. You will also require a scanner to look at the batch numbers. So general practices will actually require a scan, what's it called?
Barcode scan.
A barcode scan. Now, my practice doesn't have one, so we're looking into that. But it's something that I'd like the PHN maybe to look at, what's available.
I'll get our team on tomorrow to looking at where they can be purchased from, etc. I'll absolutely get onto that. Yep.
Well, 1,000 practices across Australia will need it, so let's do it for the PHN.
Kimberly's online. That's a first job tomorrow. Certainly take that. Under accreditation, timely access to defibrillator is adequate, but this is not mandatory. Again, this is it's exactly the same standards as you would use for your normal vaccination programs.
Yeah, look, John, I don't think it does say that in the EOI that you have to have a defibrillator. Not that I read, but certainly I would highly recommend that. The most important question of everyone will be whether they've got allergy or have had previous anaphylaxis. In the data that's come out from both the States and United Kingdom is that about 1 in 100,000 patients who have received a vaccination, this is the Pfizer vaccination, have had an anaphylactic reaction, usually by 13 minutes post-vaccination. And therefore you must have adrenaline, you must have means of resuscitation. And so it probably doesn't require absolutely a defibrillator. And I guess one of the reasons why the government probably have put a stipulation on accredited practices is to make sure that they do have access to appropriate resuscitation procedures in place.
I think what is being referred to there is in section 1.13. Does the practice have ready access to appropriate emergency equipment, including adrenaline, oxygen, and a defibrillator? If that is at odds with the accreditation standards, then I'll take that up with the department.
Yeah, I mean, some would argue that access to a defibrillator can be, you know, a lights and sirens ambulance within a reasonable time frame to assist a good resuscitation, which happens at the beach or shopping centre that may not be able to access the defib. But certainly, I should know this, but I don't think a practice would not be accredited if they didn't have one sitting in their rooms.
I'll get clarification tomorrow from
the
relative accrediting organisations. How can we best identify information on vaccine risk benefits as we're required to consent? Karen, your question.
Okay, so if we're going to use the national booking system and it works and it comes into our practice well, then we should be able to consent our patients online, and that should come through the national booking system. And I have heard some discussion that if a person is unable to do that online, and the practice will be able to help them do that. But it's a question that every patient getting a vaccine, no matter what vaccine they get, must be asked each time. So certainly we need to be having that kind of discussion, I guess, prior to the vaccination if we can. And on the day, definitely, I guess risks and benefits are that type of thing that we do every time we actually provide medication or any form of management, including a vaccine, Fiona. So it's going to be difficult. That timing is going to be hard for people we don't know particularly, but it is a question before every jab, even though you might have the best medical records in the on the planet.
We need any consent from relatives of residents. I'm assuming that relates to residential aged care facilities. Again, that depends on the individual. Some people are able to give consent for themselves, and we would expect that they would, and others have a nominated carer or guardian. So the normal consent processes will apply there.
Yeah, and I can't emphasize enough of the GP's role in this prior to vaccination rollout into aged care facilities. So start talking about it now with your patients and their families.
Yep, I'll be participating in a discussion with some residential facilities tomorrow, and I'm going to provide the same advice. Yep, good point. Aboriginal health workers in AMSs are doing COVID swab in the community. Will they be eligible? I'll take that question on notice. To be quite honest, I don't know the answer to that.
My answer to that is yes.
Yeah, I would say so, but I'm not going to. They're at risk, so I'd agree with you. I just need to clarify and make sure. If COVID vaccination is voluntary, why has the flu shot for 2020 compulsory? Doesn't really make sense for all residents and visitors need. Look, Shane, that's a bit of an evolving space in terms of the vaccine for COVID. The flu vax is a well-established vaccination, and it may be that some people, some facilities, and in fact, there will be instances in some workplaces where it is mandatory, but at this point in time, what the government is saying is it's voluntary for the community. Individual localities like residential aged care facilities will be considered separately, and we'll follow up on that.
Yeah, John, I would say that it will be a requirement by most aged care facilities to show that you have been, by the operator, that you will have a person visiting will need to be vaccinated. Remember, the vaccine is not going to stop COVID. It's going to reduce the infectivity. So the idea will be to actually reduce the probability and infectivity for our most vulnerable people in our community, and that is the aged care community. So we probably will need to be vaccinated if we go in to those places.
There's a question about the no item number for nurse practitioners. I'll follow that up. It's a question I need to ask for nurse practitioners. Happy to do that, Tony. David, will the vaccine, I think Karen, you just answered that question around the spread. Will the national, with the national booking system.
Can I just say one thing about that? Sorry, John, for interrupting. But look, it does appear, because we're not going to be vaccinating children under 18 for Pfizer and possibly under 16 for the AstraZeneca, but we're not sure of that age group yet. We will have a third of our Australians not vaccinated, so we cannot ask for herd immunity at this point in time. We need to actually realise that a vaccination, when you have it yourself, will hopefully reduce your infectivity if you get COVID. So we still need to do all of the very important things within our lives now, which is hand sanitisation, catching a cough, the 1.5 metres, and just be very mindful that COVID's still going to be out there and it's still going to be spreading in our community. We don't know what it's going to look like once we've started the vaccination or even in a year's time. But my recommendation is that we inform our patients as best we can that in fact what we're aiming to do is that all vaccinations that are going to be TGA approved will actually be able to reduce the infectivity of COVID if they themselves get infected. And therefore, if you've got enough people in community, then that will actually assist everybody around.
Sure. Helen's asked a question about the billing model. That has been, I did send that through to the department, Helen, and I've taken the initiative to raise that again on tomorrow with them. So I'll follow up and we'll provide advice. I'm not sure whether it will be reviewed, but we'll certainly follow up. Will small practices who can only provide 1B vaccination services out of hours be considered? Look, this goes to Karen's point about everyone should submit an EOI. Please don't think about the size of your practice. Put an EOI in and we can then work with you. If we don't know that you're interested, we can't work with you and we can't help government prioritise the locations, or if we get a good supply of vaccine, we can't spread it further and wider. Does a GP have to see the patient bill? I think you've already dealt with that one, Karen.
Yeah, it appears that John, it appears that the GP needs to be involved in supervision.
Yes.
Probably doesn't need to put their head in as long as all of your processes are appropriate and you've got all of the systems in place that the GP is within reach for medical supervisions. And again, it's predominantly so that the history is taken, the appropriate people are being vaccinated, and that you're aware of what to do if you do get an anaphylaxis or an allergic reaction. Remember, the majority of allergic reactions or adverse effects, rather than allergic reactions, will actually be a sore arm. And again, I'll just let you know that 1 in 100,000 patients had anaphylaxis. So the number of patients actually were very few, none of whom have died. And those patients, a couple of those, or some of those, did go to hospital, but they all were discharged without harm. So it's going to be unlikely, but it may happen, and we just need to have all of our processes in place, just like any other vaccine.
Yep. We do COVID swabbing in our car park. Will we be part of 1A? Again, we've answered that. We hope there will be, and we'll certainly be pushing for that. Should it be compulsory for staff in GP practices to be vaccinated? That is a question for the GP practice as an employer, and a discussion I would suspect you need to have at a practice level as to whether you want your staff to be vaccinated. What are you going to do, Karen?
No, nothing can be mandatory, unfortunately, and I certainly would actually make sure that I give them as much information and recommendation. There's a possibility that we may not include the staff who choose not to have their vaccinations in the front line of patients, but at the moment, with all the screening that most of us are doing, or all of us hopefully are doing within our practice, the risk of a patient with COVID coming into our practice is low. However, we know that they may slip through. John, just one more thing with that. One of the recommendations that's come out from the community practice that I've been involved in is maybe to stagger the vaccination of your staff and not to do them all on one day, so that in case you get some staff who do have a bit of a reaction or get a mild fever or so, because you may not be able to tell whether or not a mild fever is a potential risk for COVID, or whether or not it might be vaccine related. So it is suggested maybe to stagger our staff over a week or two, vaccinating them. It's just an idea.
Many patients are anxious about strangers giving them vaccine that's been pushed through TGA approval quickly. Some may decline if their GP, yes, that's been thought about, and that's the person's right to decline and wait until their practice is then able to vaccinate. That's entirely their choice. Yeah.
Again, John, I think the important thing is that we can all do some mopping up as stage 2 and 3 come in, and hopefully this is actually spread out to all general practice. The other is that information giving that we do so often every day with our patients and our community, is to try and provide as much information as you can, and to let your patients again know that the ideal is that this vaccination, we're not the first to use it, and that that millions of people have been vaccinated overseas with exactly the same vaccines, and that the side effect profile is low at this point in time, or adverse reactions, and really time is going to tell as to what it's going to look like post vaccination. But when you talk with all of the doctors and scientists involved in the production of these vaccines, they have been produced along the same lines as many other vaccines that are available and that we are vaccinating our patients with. So they do appear safe, and we're very lucky that yet again that we are watching what's happening overseas before we give them.
Thanks for that, Karen. Will the government make it clear that the patient's usual GP will? Yes, that's part of the comms that is coming out, Natalie, both from the department, and we will be supplementing that locally. What's the time frame? In what time frame will phase 1B be happening? As soon as the vaccine clears TGA approval and we've identified sites. Simple as that.
Oh, John, it's actually more about when it comes to Australia. So, when you think about it, it's the TGA approval will probably come through soon, but it's actually about supply, and the supply lines will be pretty much when we're ready to go.
Yeah, so given that the AstraZeneca is being produced here in Australia in Melbourne, I believe, the supply chain will be much shorter than for the Pfizer vaccine for 1A. So hopefully supply will be will grow quickly and be available earlier after it's been approved by TGA. So we're not reliant on flights from overseas for the AstraZeneca vaccine. What time should we allow for each vaccine booking? Flu clinics, we usually book them in every 5 minutes. Karen?
Look, I would say yes, if you've got capacity to do that. I mean, certainly if you know your patients, you're going to be able to do 5-minute appointments. If you don't know your patients, I think you're going to be very lucky to gather all that information and vaccinate them every 5 minutes. But again, it's about how you feel you can do that in your practice. And it's not, I mean, we are told we've got to be savvy in this and we've got to do it quickly, but realistically, you've got to actually really think about, you know, you can't burn yourselves out before you start. So really be realistic, and I think be upfront. Write that in the free text in your EOI again. Tell John and his team, and then the Commonwealth what you can do, what your expectations are. And I think if we all let them know that we run really good flu clinics and that we're happy to actually do similar as to the flu clinics, then that's reality.
Yeah. We've already talked about the flu vax, and so you're saying the Commonwealth decides, but it sounds like the PHN is screening the applicants. No, we're not screening them, and all we're doing is making sure that the information contained in them is complete. In other words, that all the fields are being filled in, and that when there are a number of practices in the one locality who have expressed an expression of interest, we will provide advice to the department on proximity, size, scale, and ensure that the contents are accurate, just so that the department make an informed decision on the locations. We're working with the media so there's no mass panic as occurred with the flu vaccines. Yes, there is a significant media campaign being developed both nationally and locally, and I understand from the department today that the national media campaign will start tomorrow, so it'll be on your TV and radio. What about GPs who work in public hospitals as VMOs? They're considered to be staff of the LHDs or contingent workers, so they'll be part of the phase for that. Will GPs have people who are not patients of their practice booking in? Yes, through the national booking system, it is likely that you get a patient who is not a regular patient of your practice being allocated to your practice if you submit an EOI. The more EOIs we have, the better the opportunity to vaccinate your own, because you'll then come up on the list of choices. What are the predicted numbers for the region in the first phase? That really depends on the availability of the vaccine, to be quite honest, Sam. The more vaccine we've got, the more people we can vaccinate. And the more sites who put an EOI in, the more people we can vaccinate if there's available vaccine. Adrenaline comes and goes as far as availability and expiry date. Any assistance will be available if we hit the... look, I understand that the government have made inquiries about additional supplies of the consumables, not only the adrenaline, but others. But I would suggest that if you're putting an EOI in, then you should look at your stock and its expiry dates, etc. Is there information about the vaccine for pregnancy? You've already dealt with that, Karen. Watch this space is not good enough to answer a 6-day. Unfortunately, it is, Natalie. It's a changing process, and with all due respect, we're doing what we can. Do you have to use the national booking system? Yes. Has there been any update about whether or not syringes and needles will be provided? I've asked the question, Michelle, and my understanding is that they'll provide answers to that in the FAQs in the next 24 hours. We've already answered the question about the nurse practitioner. Will admin corporate staff be in 1A or B, organisation that has residential aged care? So I think we've answered that. So as a GP solo practice, do I have to apply to be able to vaccinate for COVID? Yes, you need to put an EOI in, and you need to just complete the details for your practice using the information that's captured in there. Sorry, I've just lost my place. Has there been a consensus reached on generic patient consent? that's being worked through, Carolyn. My understanding is that there will be a model consent form provided if facilities don't already have it.
John, I think also that will be part of the national booking scheme,
System.
that the consent.
Yeah.
If you've ever been to a respiratory clinic, a GP respiratory clinic, and they use Hot Docs, which is a system where you answer a number of questions, which actually gets loaded directly up into the database for them. And that will be a very similar kind of data collection point. And one of those, I believe, will be a consent form that it will be, but you'll need to just probably recheck that the patient has consented. You'd expect that they will when they've arrived for it.
Yes, yeah, a bit like flu vax.
Yeah.
We've talked about flu vaccine availability and the timing of those. If a standalone vaccination day, will there be a limit on the number seen? Depends on your workforce and your space. I would say if you've got the space and the ability to do at pace, then there will not be a limit. It'll be limited by the availability of the vaccine, how much supply you've got. The next question, where do I apply for the EOI? It is contained, there's a link in the pack that was sent round prior to this webinar, but if you don't have it, please email me on the email address that I provided earlier and I'll send you a copy, Sachin. Are people that refuse to be immunised against COVID be refused to visit relatives? Evolving space. Again, we've talked about it, but it is an evolving space, and it's very likely that there'll be similar processes to the influenza vaccine, but it's not clear at the moment. Can a new practice that's not been accredited be registered for the EOI? If you are going through the accreditation process and awaiting your result, then put an EOI in. But put a forward date. If you've not commenced the accreditation process, then you really need to start the accreditation process before you put your EOI in. We've already talked about flu vax. We don't know about mobile hubs at the moment. That is likely to be covered by the other operators who'll be doing the residential aged care facilities. Will ultra-low temperature storage areas be required or provided for regional hubs? The regional hubs will be large hospitals and facilities. For practices under 1B, they will not require a ultra-low. It is standard vaccine storage fridge. What's the process if someone doesn't have a regular GP? They'll still be able to be vaccinated, Jack. They will obviously be allocated to one of the centres that are, or one of the facilities services that's providing it. And one would hope that everyone's got a regular GP.
John, I've just read some really interesting data in that they say that up to 90% of Australians have visited up general practice in the last 2 years. However, up to about a third of Australians don't actually identify a general practice as their own. So it is an issue, and there's a potential possibility that this is why if you do say put your hand up for an EOI, they're going to want us to vaccinate patients or people who don't have a GP already, or from other practices or from other areas.
We're rapidly running out of time. In fact, we're slightly over time. So what I'm going to do is take all of the questions that are in this list and provide answers to them over the next 24 to 36 hours. There are a couple of questions that I can answer. Someone said is it correct there's no Pfizer vaccine here yet? That's incorrect. There are actually stocks of Pfizer vaccine in the country. They're just not being distributed until TGA approval was given. So they are here, but they're not being distributed. It's not a huge supply, but they're working on it. Can you see any others there that we should probably
Yes, John,
answer?
I can. Yeah, Maria's asked about the National Adverse Reaction Reporting Mechanism. It's a great question, Maria. And certainly there are 2 programs or 2 apps out, which, John, I know that SmartVax is one, and off the cuff, I can't remember the second one, but I'd highly recommend practices look into it. It's a free system that has been very well trialled. It sits in the background of a number of our medical record systems, and it will assist practices in identifying adverse reactions in that the patient themselves is identified, linked to the AIR and identified on day 3 or 5, get a text or some form of I guess message asking them whether they've had an adverse reaction. They can report back, and that information is actually given to the practice through your own medical record systems. So I'd highly recommend, probably if you can, John, and your team, have a look at
We'll
those.
get some details of those.
Reporting. Because it is something in general practice we should probably have linked into our record keeping anyway, and not just hear about it months or months later that somebody did have an adverse reaction.
Just one last one from me. Pam Evans has asked, when will we know if we got the vaccine through the EOI system? We will know, or you should get an email saying that you've successfully submitted your EOI, and then you will be prioritised by the system and some input from the PHN and the department, and they will ultimately they being the department will ultimately let you know when vaccine is available to administer. Practices who successfully submit an EOI will be notified by the system straight away that it's been received. We'll then assess them and let you know if there are gaps and come back to you to have those resubmitted.
John, I think probably most of the questions there are a little bit similar to the ones that we've already covered, but there have been multiple questions. I'd actually say it's been fantastic to be part of tonight and to see so many submissions of questions, and I can only just say that things are changing every day, and I think if you can stay in touch with your local reps, the people from the PHN, the communities of practice, and just a plug out for Marie Puxty and Fiona, who are the other clinical, the chairs of the other clinical councils in Hunter, New England and Newcastle, and they are very willing to answer your questions as well in your area. So certainly Central Coast, we would love you all to be involved in some form of just information sharing. So we recommend that you join our community of practice. And I know that Marie and Fiona are waiting to hear from you guys within their organisations as well.
Thanks, Karen. Thanks for your help this week with this and today in particular. I really appreciate it. Thanks everyone for participating. We will answer all of these questions over the next 24 to 36 hours and provide you with a summary of those answers as best and as quickly as we can. Again, thanks for participating, everyone. And please put an EOI in so we've got good representation across our footprint. Thanks, Jenny. Over to you.
Thanks, everyone. Thanks so much, John and Karen, for your time tonight and your patience. We've had an incredible amount of questions that have come through. We will try and put it as a resource on the website with a copy of the presentation and the slides. Thanks everybody, and catch you at the next education session.
Thanks,
Thank you.
Jenny. Bye.
Good night.